All right, let's let everyone come into the Zoom room. Everyone's coming in. Good evening, CSOMA community. Happy May. May 12th is my brother's birthday, actually. So it's a great day. And welcome to another Tuesday night webinar series. We're loving the 2026 program, which means all of you being here as part of it. This evening series has been designed to do a lot of things. One is to build community and help us connect and come together and bask in this amazing medicine at least once a month for a couple hours so we can keep getting filled up and renewed. There's been a lot of amazing connections that happen with other people meeting each other in the chat. So if you're into it, share where you're calling in from. Where are you tuning in from? Because we get people from all across the country and certainly all across California. So it's a fun way to share. And we also have just been able to deliver so much incredible material through this Tuesday night. We have an amazing speaker tonight, Josh Margolis, and we're able to just cover a lot of topics. There's really cool stuff coming up. Please make sure you go to csomaonline.org to see what is offering. Next month, we have Dan Bensky coming. So we're really excited about that. So don't miss our June program and just so many amazing speakers. We plan to keep this program going through 2027. So if you have ideas, if you want to speak, because we know there's a lot of leaders and teachers out there, if you're interested, reach out to me, ra@csomaonline.org. Kim, maybe can you throw that in the chat? I'm Ra Adcock. You're the executive director of CSOMA and a licensed acupuncturist at UCSF and the director of pediatric integrative medicine. Kim Newman is amazing. If you've ever dealt with anything CSOMA, you've dealt with Kim. She keeps everything running and does a lot, our communications and outreach, and just make sure everyone's really happy. And then you'll see Josh Margolis here, our special speaker tonight. We're going to introduce him in just one more minute. So if you're needing credit for tonight, and we love to give you guys CEUs for this. 2 CEUs have been approved by the California Acupuncture Board. Then we've asked you to make a donation to CSOMA. It helps us in our lobbying efforts and our advocacy work. When you guys get your CEUs from us, we try to give you really low cost, high quality CEUs, and you guys keep us going so we can keep fighting for the profession. And boy, has it been a fight this year, right? So please follow along for updates on AB 2497. This is the physical therapy profession trying to introduce dry needling and e-stim, which means retention needles, into their scope. We are fighting this every step of the way, and we need you to help. We need support from you guys. We need membership, so we're representing larger numbers. We need you to follow along in the newsletter and see what actions you can take to advocate for acupuncture, for TCM, for all the things we've trained so hard for, which really ultimately not just means good profession for us, but it means the best possible patient care that we can deliver. We have to protect the delivery of needle medicine to make sure that it's safe and that it's effective and that the standards in California remain as high as they've always been. So please, follow along. There's a lot of petitions that come up and other actions that need to happen as we battle this through the California legislature. We'll be having a town hall again soon, and every update is on our social media. But hey, you're already here, so that means you're part of the community. So thank you for being here. Thanks for being part of CSOMA. Please look into membership if you're not a member. There's a lot of different tiers you can be at, and membership pays for itself, especially when you get your CEUs with us on nights like tonight. So, Kim, what do folks need to know from the admin side of things?
Okay. So you will receive an email with the links to your certificate. You're just going to have a few questions to answer, and then it will generate a certificate for you. So just pay attention to your email. You may have received it already, but I will send out another one.
Great. All right.
So Ra, some are saying that there is an echo. It's not everyone, but there are a couple, it looks like, that are experiencing an echo. I'm not sure.
Okay. And it could be my computer's been a little funky lately, so I'm going to mute soon. And I don't know if it's echoing in your from you, Kim? I'm not sure. Yeah, Josh,
Yeah.
you're hearing it. Okay, we're gonna try and deal with this. Please in the chat. Thank you for that kind of technical update. We don't know that's happening. If is it still happening right now? Let us know and we'll keep troubleshooting. So still an echo. All right. Huh. Okay. I'm gonna get
Well,
some ear.
let's get started with
Yeah.
Joshua,
Yeah,
and we'll
I
see
think
it away.
so. Josh, I'm gonna turn it over to you. People are getting an echo. Well, some people are. All right, Josh, I'm gonna introduce you and then I'll turn it over to you and we'll mute. And then folks at home, let us know if there's an echo or not. I'm hearing no echo. Okay. Not sure, folks, you guys. So Joshua Margolis, a doctor of acupuncture, licensed acupuncturist. This is really, Josh, you're moving into like one of the like young legends of the profession. You've been making a huge footprint. You have a lot of really original viewpoints that we're going to learn more about tonight. 20 plus years of full-time clinical experience. I can't even imagine the number of treatments that you've delivered to unlock this information for us tonight. I just learned Josh practices in Santa Rosa, not too far from me here in Marin, and really does a lot of integration with medical acupuncture, uses dry needling as a technique, a lot of advanced manual therapies, which I imagine has been part of what's informed what you're going to share with us tonight. And I see here you have a specialty in treating musculoskeletal conditions and chronic pain. And we're going to learn more about how you do that and your approach. Thank you for being our speaker here tonight. Josh welcomes questions in the chat. We'll be following along and alerting him to any timely questions. And for bigger theoretical questions, put those in the Q&A and we'll have a few pauses for those tonight. Josh, I'm going to turn it over to you. I can't wait to be your student tonight. Thank you for being here.
Thank you. Thanks, Ra. Thanks, Kim. Thanks, everyone, for coming tonight, taking a work night for many of us. I saw Yanni, you're here all the way from Finland, so that's amazing. I think that's a record maybe for us if we had anyone that far. Anyway, that's great. So I'm Josh Margolis. I'm an acupuncturist here in California. Been licensed since 2001. This was my 25th year in February. So that's very exciting. This work is very exciting for me, and I'm really happy to share it with you. It kind of came out in COVID that I started teaching this at the beginning, because I was looking for something I could share online in this format. So there's a lot that we can discuss theoretically that you'll be able to go back and use pretty directly in your clinic. What else do I want to say? So I do indeed have a practice full-time, treating primarily musculoskeletal complaints, complex chronic pain mostly. I trained as an osteopath in Canada, which makes me not a physician in the United States. It doesn't give that right, but I did learn the manual therapies and I've used those a lot. And that does indeed inform where a lot of this comes from. And I think for me helps to make a model that is useful, predictable. It helps us speak with our colleagues in other professions. It's been very helpful to speak with patients, and really I like having um, structures that allow me to think myself out of a corner, right? I mean, what happens when the magic point we learned from our teacher doesn't work, right? That's happened to all of us, right? You're like, oh, it works every time. And then, of course, nothing works every time. So, having some different ways to think about what we're doing. Also, to help with precision of assessment. There's a lot of clinical signs, not just frank radiculopathy like, sciatica or a cervical disc or something like that. But there's a lot of clinical signs of of a segmental nature that we'll see in the clinic a lot. And once you know how to recognize them with some simple screening procedures in the clinic, you'll be able to see this more and more often. And then you'll be able to see in real time actually as well if your treatment worked. So That doesn't have to be, what I'm proposing as models. It can be what you do already, and hopefully you'll understand maybe some of how some of the points that you're already using in clinic regularly that you learned in TCM school are functioning. Okay, so before I jump into the meat of the matter, are we doing okay audio wise? I want to make sure you hear what I'm saying. Can I just get a quick summary? We're good.
Yeah, everything's the chat. People are saying it's good. It sounds good to me too.
Oh,
So I'll let you know if it's otherwise. If it's not good, I'll let you know. Otherwise, let's just assume it's great.
all right. So I'm going to jump in and we're going to share my screen. All right. So that's popping up for you. Okay. So uh, this class, I'd like to think about, our one of our venerated mythological, larger than life uh, representative teachers here, Huato, right? And credited with the Huatuajaji points, which is not going to be what we're going to be limited to. So here's my contact information. If you have questions for me on here, um, I have no conflicts of interest. I don't make any money doing this. There's no other than I teach some courses. Uh, I did use some AI on the slides to create this wacky picture because I could never do that. But the rest was done all by me. Okay, so this is a t-shirt that I usually give away at events. So he's the original ganglionster, right? Spinal ganglia. Huato is an amazing force. So we give a lot of credit to him for where this material comes from because this was recognized, you know, 1800 years before chiropractic or osteopathic medicine had come to being. So speaking of osteopathy, this is a saying by the founder and developer of osteopathy, Andrew Taylor Still, back in the late 19th century. All diseases are mere effects, the cause being a partial or complete failure of the nerves to properly conduct the fluids of life. And this is exciting. He said this, 130 years ago. But, for a long time, we thought nerves were primarily electrical, but as we're going to see later, that there is actually two-way transmission of neurotransmitters and other chemicals like substance P through the sensory nerves, especially, which will modulate how we perceive pain and how inflammation happens. So this is really neat. He intuited this quite some time ago. So here is an embryo on the right side of the screen there. We're going to talk, before we go any further, we need to understand what we mean by a segment in segmental acupuncture. So a segment is all of the tissues sharing a spinal nerve, but we can go back a spinal nerve root. We can go back one step and look embryologically, and that means they all actually originated, those structures that share that same nerve actually originated from the same segment, which was a somite, right? So we have a matching number of somites ultimately to the number of vertebra. Some of them are reabsorbed along the way, but that's basic idea. So a segment means all of it. Okay, I'm going to come back to this concept a little bit, but the main things we're going to be looking at are the dermatome, the myotome, and the sclerotome. The dermatome is the layer of skin directly under the surface. So that's where we have our cutaneous nerves, not the epithelial layer. The myotome becomes the muscles of the entire body, and the sclerotome is the bones of the vertebral column and the ribs. And so there are other tomes that we can talk about briefly, but those are the main ones that are going to be relevant to us because we're going to be able to contact those with acupuncture needles. Okay. So in the segment, we've got nerves coming from each segment out into the periphery and back again, and we're going to have a lot of utility here. Okay, so just remember this key takeaway that every tissue remembers where it came from, right? They're all in the same family, and they will the those that share the same root, you can imagine the root is their parent, and they all share the same family. And so what happens in one part of that dynamic system will affect the others. So if something happens in your say you have arthritis, right, in your knee, but often the skin will turn red and there'll be a change in the blood flow and so on. So you can actually see that the dermatome uh, is affected, even though that uh, is not technically a sclerotomal structure, but a sclerotomal-like structure. The knee joint itself is what was ultimately originally affected. Okay, so remember, there's an ongoing relationship between the derivatives of the same segment. So health and disease, that's a two-way street. That means we can see pathological processes map out in throughout the segment, but it also means that we can provide help through that. Acupuncture at its root, one of its many pathways is as a segmental therapy. So you can see changes in the whole segment by applying a needle in one part of the segment. Okay, especially if you affect the irritated portion. Okay, so in development that you have excuse me, it's important to understand that the nerve is actually dragged along as the different tissues move through the entirety of the forms, and there's quite a bit of migration in some parts of a segment, right? You have, for example, the like top of your foot is the L5 dermatome, so that skin originally migrated from your L5 region, from the L5 um, segment, and it dragged that nerve supply all the way to the skin, that skin area there. Okay, so um, remember we said that the whole segment influences the rest of the segment. Any part of the segment can influence the rest of the segment. So stress to the tissues or irritation lowers the threshold for irritation for other structures in that and can cause changes. So, for example, John Searle did a lot of research using like capsaicin and putting just capsaicin on the skin, and they found that changes in segmentally related muscles, but not in non-segmentally related muscles, in the firing potentials and so on. So you can the whole segment is really an interface, interacting dynamic interface, I think. Okay, and noxious being non-noxious stimuli. So noxious stimuli are something that could potentially cause damage. Not everything noxious is tissue damaging. Um, for example, 125-degree water can feel hot, and you might have a withdrawal reflex, but you're not going to damage your skin at 125. 130, 140, you might, but so the nervous system interprets that as painful and creates like a withdrawal response. But not all noxious stimuli are painful. So you can see cases of people with like arthritis and so on who aren't having pain, but on radiographs or disc degeneration and so on. So those still affecting the segment and lowering the threshold of irritation for the entire segment, but it might not be crossing the threshold into actual pain. And we'll talk about that later. But basically, important to understand that non-noxious stimulus such as heat, pressure, vibration, acupuncture needles, they can raise the threshold for the irritation in segmentally related tissues. So the ultrasound is another one. So that's like the gate control theory of Melzack and Wall. Okay, so we see this stuff in the clinic all the time. So just drilling in just a little bit more, we'll talk about the dermatome, which is I mean, you can look at the details of where it comes from. We'll talk about that a little bit later. But it's the dermis layer of the skin, right? That's the where all the blood vessels and so on. So this is primarily sensory innervation, uh, and there's a lot of sympathetic innervation here. So we're constantly adjusting the blood flow and the our sweat response to uh, to control our temperature and interface with the environment, right? So uh, we got the myotome. Um, the myotome here is the muscles for the entire body. Okay, voluntary movement, and we have both sensory and motor innervation. And actually, the dermatome there are some motor innervation. The erector pili muscles and the sudoriferous glands are technically motor nerves. That's back to the dermatome. Uh, the sclerotome uh, makes the bones of the axial skeleton uh, and makes provides structure, right? There's a lot of sensory innervation here. There's a lot of sympathetic innervation here. This is a very interesting area to treat with acupuncture. Um, and I have had some really profound effects with people treating the periosteum in particular for really difficult pain cases. There's also the viscerotome, or sometimes it's called the enterotome, and this is our internal organs. This is the lining of the gastrointestinal tract and so on. These are all mesodermal derivatives, like everything else we've been talking about. Okay, there's a lot of autonomic activity here, both the sensory and motor. Okay, so here is a segment. Um, This is from Wankura Campek's book, Segmental Anatomy. Um, this is a great book. It's a really difficult read, but there's a lot of gems in here and some really good pictures. It originally was written in German. I'm not clear if the English edition is any clearer to me, but it's got a lot of interesting things. Anyway, we've got here it's a T5 segment, right? And if you're looking at T5, does my thing give a point? Can I give a pointer? Can you see my mouse?
We can
My-
see it.
oh, you can see it?
Yes. Hmm.
Okay, great.
Looks
Great.
great.
So here we are is T5. Here's in the spinal cord, but we're going to now see that some fibers here are going to go to the T5 myotome, so the muscles of T that are innervated by T5. We have fibers going back from the skin, the dermatome, that innervates T5, going back into the dorsal root here. This is motor and ventral root, dorsal root. We have coming off the lateral horn of the spinal cord going up here. We have some autonomics into the head, controlling blood vessels in the eye. We've got some autonomics coming around here going to the heart. Our heart gets innervation from about T5 is one of the main segments. It's really about T2, T3 to T6 or so. So you can see here that a bunch of structures can share that same innervation root. And so that's part of why we can see things like if people have like heart problems, they're going to have angina, they can have chest pain, not just from the heart itself, but as a projection and a referral through the segment to both the myotome and the dermatome. So people can have muscle spasms, they can have pain in the skin, and so on, all related to that shared segmental innervation. Okay, so that's a quick moment. If anyone has any questions, because we're going to dive into the actual embryology here and development. I just want to make sure you guys are clear what we're talking about when we mean a segment, because this is going to get very confusing if you don't have that particular concept.
And I'm not seeing any questions in the Q&A section and none in the chat. So
Great.
Oh,
Okay.
there's a question. So, how did they figure out the segment connection via animal studies or via animal studies? Actually, you know what? I'm gonna just
Yeah,
I don't know if you could see
yeah,
it or have.
let's hold that one. Okay.
Okay. All right.
Yeah.
All
Okay.
right. Great.
So all this action really happens, segmental action really happens between weeks 3 and 8 after conception. And you can see on the left, we start with a ball of cells and we become, it splits off into a mass of cells. Then we get, on around 10 days, we start getting the bilaminar disc. And then in the beginning of the 3rd week, we start getting the mesoderm, right? The develop a mesoderm. So before that, that middle layer starts to develop. And this is a process called gastrulation. And literally, cells from the ectoderm, right? The outer layer, the ectoderm becomes the uh, skin and the central nervous system, the nervous system primarily. The mesoderm becomes all the muscles, fascia, and connective tissue, including bones and so on. And the endoderm ultimately becomes like the gut linings and so on. There are some exceptions, but that's the general way it is. What we're mostly going to be looking at today are the mesodermal derivatives. So this is how the mesoderm forms in this gastrulation process. There's a invagination and the folding in where the mesodermal, where cells from the ectoderm actually go and become mesodermal cells. There's a couple key structures we want to look at as this process happens. So this becomes the neural groove. This hasn't sealed yet. We have what's called the notochord, which is very important in this area here, this brown area, which is very important for driving development in the embryological stages. Um, we do actually have a little remnant of it. The nucleus pulposus in our discs, in our intervertebral discs, are remnants of the notochord. Um, but it loses its function later. A lot of this mesodermal derivatives in the early stages are really gelatinous, and so that's what we see in that disc. Yeah. Anyway, so this area here, the blue, this is ectoderm. So this is ultimately going to be skin. This is the spinal cord being developed. Here we have on the sides here, these are the somites. So this is like a mass, and these are repeated in like a string of pearls. Um, we have, different bits. This red stuff is also mesodermal, which some of this will go off to form the like bones and fascia of our limbs and the like the ligaments and the muscles of the digestive tract and so on. Okay, this is a chick embryo, not a human, but by the end of the 5th week, we have a pretty similar setup to in segmentally into what we have in the adult body. The big thing that changes are that these coccygeal somites are resorbed, right? We don't have a tail, so those get reabsorbed. Um, Here you can see the different stages. So these are somites forming. They start, this is the cranial end, this is the head end, and they kind of form from head to tail and they keep processing down as we're at the same time we did uh this there's like everything's coming together and zipping up, and then from if you look from the side, the embryo is starting to curl. So there's kind of this like motion from front to back like this, and at the same time there's a tail to head curling happening. Um, so as we get later, we start looking at week 4 down here. You start recognizing things a little bit, and we will then start to see limb buds appear at the end of week 4. Okay, so that's all I really want to say about embryology for tonight. We can talk about it a little more if you want, but it's important to understand, I think, in terms of takeaways that, this has been happening a long time. Our body is much more interconnected than anatomists have thought, and it's in the word itself. Anatomy means to cut apart, right? So as we are really looking at living systems, this is a very integrated whole. Okay. So this slide is quick review of the anatomy of the spinal cord. So we have the posterior horn, we have the lateral horn in the thoracic vertebra, and we have the anterior horn. Okay. The posterior horn or dorsal horn, this one is going to receive sensory input. Okay. The sensory nerves live here in the dorsal root ganglia, and they have projections. They're kind of like a T, if you remember, and they send projections both into the spinal cord and to the periphery. What we know now is that substances like substance P and uh, glutamate and so on can actually transfer down. We have a dorsal root reflex where there's actual communication from that dorsal root back down sort of the wrong direction, if you will, what they call the retrograde flow, down towards and there's nerve impulses even from the dorsal root towards the periphery. But in the simple model, we're going to just think about it as, and that's going to be relevant when we talk about pain. But for now, we'll just think about it's sending information in. This is where things are processed, are brought into the cord. This lateral horn is in the thoracolumbar vertebra. This is where our sympathetic motor neurons. So sympathetics, we're thinking blood flow, gland function. Blood flow, gland function. That's the motor output. So this is motor. And then the anterior horn is motor. So this is going to the somatic nervous system, so the soma, excuse me. So that's your muscles and so on. Okay. So peripheral nervous system, everything outside the brain, right? Except for the eyes, right? So 12 cranial nerves, 31 spinal nerves, 8 cervical, 5 lumbar, 5 sacral, and only 1 coccygeal is left at the end of the day. The nervous system, peripheral nervous system is broken up into 2 parts. So we have the somatic nervous system, which is controls sensation and motor for the limbs and trunk. And we have the autonomic, which controls involuntary responses. So that's like smooth muscle contraction, glandular function, and sweat. Blood, like smooth muscle, so that's like blood vessels. That's your, the lumen of the muscular layers of the intestinal tract, the smooth muscle that dilate or constrict your bronchioles, all that stuff. The bronchi, all that stuff is controlled by the autonomic nervous system. All right. So key things to know about the autonomic nervous system. So that there's always going to be a synapse with another neuron before, not, there's an exception or two, but there will synapse with another neuron before innervating the target organ. Okay. There's going to control involuntary responses. So that's going to be like cardiac muscles, that's going to be glands, all these kinds of things that we talked about, endocrine and exocrine glands, sweat glands, etc. Okay. We have 2 divisions of the autonomic nervous system that are relevant here. They're the vagus nerve, or sorry, the parasympathetic, which is primarily run by the vagus nerve. There's a few others in the head, and there's some sacral contribution too, although that is all now kind of in play and changed. They might we might have the parasympathetic outflow from the sacrum might actually be sympathetic, right? But parasympathetic being the rest and digest, sympathetic being the fight or flight responses. And we're primarily, from our standpoint, we're going to be looking at the sympathetic nervous system, right? So that it's there to get your body ready for danger. It's mediated, the nerve roots are coming off of T1 to L2. But what's interesting here is they will go into these ganglia up in front. So we have outflow at many, many, many levels, even though the root is up here. Okay. And so a sympathetic nerve, sympathetic response, because it's the fight or flight response, is designed to be quick. So, you might have, uh, you know, T10 here, it might be sending a bunch of fibers down here and affecting, multiple targets very quickly. It spreads the news very, very quickly. Okay. There's generally short preganglionic fibers. This is just the anatomical piece. So before it synapses with another nerve and goes on. And, this is norepinephrine and epinephrine. So the sympathetic nervous system is going to be the piece that we're going to look at quite a bit. We're going to see signs of sympathetic dysregulation in the periphery, and with practice, they're really easy to see. So what are we going to see? So the sympathetic nervous system does a couple key things. And in the skin and the dermis, it's vasoconstriction, right? So if you got a bear chasing you and it's going to slash you, it's actually to our benefit to have less blood in our skin and more blood in our muscles so we can run. So we'll bleed less and we'll have more power in our muscles. We're also going to see an increase of sweating. Okay, there's a sweating response that is mediated by the sympathetic nervous system. And then we're going to often see, especially in chronic cases, you're going to see some degeneration of tissues, right? You might see flaky skin. You might see blue, poor circulation signs, what we call blood stagnation in Chinese medicine, because of that superficial vasoconstriction. And that can go on for a long time. Another thing we're going to see related to that is a lot of subcutaneous edema. So we're going to have skin rolling, like thickened folds in the dermis when you try to roll the skin like ravioli or something like that up and down the spine, you're going to see thickening. And so we can put all these things together and see where the nervous system is irritated. Don't worry, we're going to come back to all of this, but I want you to know that understanding a little bit how the sympathetic nervous system works will really help you understand how you can help your patients. So you can see, for example, if someone has say a trigger point in tibialis anterior. Okay, tibialis anterior is on the front of your shin there. Stomach 36 is commonplace for that trigger point. So if that person has irritation in that part of the segment, right, then we should, and often will, find in L4, which is the main, a main nerve root supplying the tibialis anterior. We should see an L4, which is the skin over the front of the shin, and in a similar area actually. So they line up pretty well in this one. So anyway, you see when you do skin rolling there, you should see thickening. You might see a change in the sweat in that area. If you go back to the spine at L4, you'll see those changes as well. So especially if it's been more chronic, and there's a lot to say on this, so we'll come back to that. But just know that you can interrogate the whole segment to find out what's going on. You have a lot of targets to look at.
Hey, Josh, just a quick little note. Leon is encouraging you to use the pointer on kind of diagram slides, because then the folks are saying it's a little easier to follow along with what you're saying.
Oh, sure. Yeah, happy to. So here's the ganglia here. So what happens is the sympathetic nervous system is you're gonna send out the nerve root is gonna come out here, you know, and it's going to either travel to one of the celiac, like the celiac plex, the superior mesenteric, or the inferior mesenteric plexi. Okay, those are sympathetic ganglia. Ganglia is a grouping of cell bodies. So some nerves will pass without synapsing. They'll go to the ganglia, and then they'll synapse there, and then they'll go to the target organ. And some things for like blood vessels and so on, they actually synapse in the ganglia itself. So there'll be a very short fiber there, and then it'll go up to the like blood vessels and mucous membranes and those kinds of things. So and then if you zoom in on this, and so in the handouts, I don't know if Kim, you put those out yet, the links to those. You'll have these pictures, and I have a segmental cheat sheet, which will help you if you can't remember all this stuff off the top of your head. It's really helpful to have in the clinic. In each clinic room, you can help yourself do this pretty quickly and figure out kind of what levels might be involved and where you might want to look and see if something unusual is happening. Um,
So Joshua, I'll add that to the chat for everyone right now.
Yeah, so the slides are in there. There's a segmental cheat sheet, and then I put a list of like books that you can look at or YouTube videos that I think are pretty helpful to understand this stuff if you want to go into more detail. This is this is a very this is a survey of this material. So there's a lot more to get out of here. But, a key thing to understand is sympathetic nervous system, fight or flight, blood vessels, sweat glands. So that's going to be changes in circulation. You're going to see some edema, and you're going to see some changes in sweat. So these things are the main things you're going to see in the clinic related to the sympathetic nervous system. Okay. So on the left here, we're looking at heads zones. These are areas that, common areas for referral. So the diaphragm, right? See, 3, 4, 5 keeps the diaphragm alive. The dermatome for C4 is the top of the shoulder. So diaphragmatic problems can be in the shoulder. That's why liver and gallbladder problems can manifest in the shoulders, right? They are innervated actually by the phrenic nerve. There's some of their sensory innervation. So, people can mislocate the source of the pain. Okay. You can see in the heart here, T3, 4, 5, right? So heart pain over the chest, right? We have the esophagus is T4-5 mostly, so that can be the middle of the chest. Stomach, people can have pain all through these areas. So these are not always precise. Okay, so especially with the sympathetic aspects, the there's a lot of overlap. So, when we say stomach, we're going to say like T5 through T9 or something like that, right? And the small intestine, T10 to T12, large intestine, T12 to L2, and so on. So, and that can be different from person to person. So there might be contributions higher or lower for different people. The head gets all of its sympathetic innervation from the upper thoracics, and there are three ganglia in the throat, right? We've probably all heard about stellate ganglia. That's a sympathetic ganglion, and so they use that a lot to treat like really difficult pain in the arm and so on. Stellate nerve ganglia or stellate nerve blocks. Yeah, so that's a sympathetic ganglia, but it's the originating roots are lower in the thoracic spine, even though the ganglia is higher. Okay. So anyway, you can see these are all pretty common things we'll see. Okay. Here's a nicer picture specifically of you can see of a segment. Okay, so here's the dorsal root. Okay, sensory nerve sending projections out into the periphery and the skin here, and then also into the dorsal horn or posterior horn. We can see some connection here to the lateral horn. The lateral horn is where our sympathetic innervation's from, and you can see if you trace some of these around, some of these go to the synapse in the ganglia here, and then go out directly to the skin. So that's a motor nerve going to affect the sweat glands and the blood flow to the skin in this area. Um, and then we have the also we have some here. I'm going to trace it if I can get on the right one here. Yeah, on that one. Oh, this is getting information back. It's a little confusing. Anyway, there should be one that's coming kind of through here and is by going through the ganglia, and then is gonna, this one will like innervate in like a cardiac plexus, but the ganglion. But anyway, um, down in here, these are motor, and those go to the myotome. So in this case, we're looking at the rib. So this is again like a T3, 4, similar to that picture I showed earlier, but should make a little more sense. The cardiac ganglia, some of them are in the throat. So that's what we're looking at there. Okay. We're going to come back to all of this in a couple different ways as we go here. Is there any questions about this? Again, I'll stop kind of at each section that's related. If it's sort of a general question like the one earlier around like how did they figure this out, we can talk about all that stuff at the end or during longer question breaks. We good?
I'm just seeing that one question for the end, and I'll let you know otherwise.
Okay. So segmental acupuncture is what we're here for tonight, right? This person failed clean needle technique class, okay? Because they grasp the shaft of their needle. All right. So stimulating any tissue affects the entire segment. So when you put a needle in, there are certainly local effects. There are brain effects. But what we're talking about here is the segmental effects. So some cool examples from the clinic, you can do periosteal pecking of the tubercle of the humerus, so near the rotator cuff tendons. By tapping on that tissue, that can affect the rotator cuff muscles, which are C5, C6, right? C5 is the origin of that, sorry, the um, the tubercle of the humerus is part of the C5 sclerotome. So that, even though it's not embryologically derived from that part, it is part of it is part of the sclerotome. So the bony tissues, the joints and ligaments are all considered sclerotomal. So by pecking at the C5 sclerotome, we can actually change the tone and irritability of all the muscles in C5, as well as the skin and the pain sensations. And you also can change the paraspinal muscle tone. And you may be able to see changes in the sympathetic signs at the C5 at the spine. So all of that can happen from one needle. And there's ways we can take advantage of this um, uh, and see it in real time in the clinic if you pay attention. But you have to assess. If you don't assess, you won't see it. So you don't know that it's happened. Okay. Another point we like a lot another point we like in acupuncture is spleen 6, common point, right? And that's mostly innervated. That's a tibial nerve. That's about S2. And that can affect the parasympathetic flow, the uterus, prostate, gonads, colon, etc. Okay, so sympathetic, Ba number 2, that's our big point for treating the genitourinary system. Spleen 6 is on the other side, so this is in the periphery. And so depending on how you needle it, you could be needling the sclerotomally, you could be needling in the dermatome. If you're needling in the dermatome here, you're actually more like at L4, so it doesn't match. But if you're into the tibial nerve deeper, you're definitely in the territory of S2. I think it's an important thing to realize, I guess, when you look at the charts, Let me see if I have a good dermatome chart quickly. Sorry for spinning these. That one doesn't show the legs. Okay. If you have a dermatome chart, maybe at the break when we have a moment, I'll pull one up and we can look at it. But you can have quite a bit of mismatch topographically between what's on the surface and what's deeper. There's a slide I made for the last class I taught, so I don't think it's in here. So I'll pop it in for later. But it shows that, you can have, like, for example, um, you know, on the shoulder, on the top, on the, like, over the clavicle, our skin till about here is innervated by C4 primarily. But the muscles underneath, you got the pecs, which are like C8, C7, C8. Then, you've got if you get down into the deeper layers, the ribs and the muscles between the ribs, or we're getting into T1, T2, T3. So there can be, like, one needle, you could be affecting multiple segments depending on the depth that you go. It's kind of interesting. So it helps to really get those maps pretty clear in your head eventually. And you get into the limbs, like, so the medial leg, like from the knee down, that's saphenous nerve territory on the skin. That's like L4. On the, like, from like spleen 9 along the spleen and liver meridians, from spleen 9 down to like spleen, kidney 3 along that whole area. That's all saphenous nerve. That's L4 on the surface on the dermatome. But the muscle, if you go in, you're at like S2, S1 on the gastrocnemius and the extrinsic uh, foot muscles. Okay, like tibialis posterior and so on, tibialis posterior and flexor of the toes. Okay, so let's look at some strategies here. So axial skeleton is your skull, vertebra, ribs, and sternum. Okay, peripheral skeleton is and pelvis. Actually, this sacrum. Actually, the ilia are part of the peripheral skeleton. So peripheral is everything else. Okay. So we can go axial to axial in treatment. So these are some ways we can look at the treating time. I apologize. I'm being a little vague here. For treatment, we can look at different ways to approach this. You can go within the same region, so axial to axial, so treating opposite, like Kwato Jaji. So if you have pain on the left side of your spine, we often put needles on the right side of the spine, right? This is nothing new. We can do axial to peripheral. So good example of this is you're treating, like, in the neck, you can see C4-5 and to affect like shoulder pain, right? Or you can treat in the lumbar spine to affect the legs. You can do peripheral to peripheral, so you can do, like, within the same segment. So for example, you might treat, like, if someone has a damaged their biceps tendon, you could use the deltoid as an adjunct to help you get a stronger effect by putting more a non-noxious stimulus into that same segment. Or you can do something we do in acupuncture a lot, which is contralateral treatment. So you can treat on the opposite side. There are cross-spinal reflexes that work both to benefit and to harm uh, in the patient's life. So we can needle on the opposite side and have good effect. So this is useful certainly when someone is in a cast or has a burn or something that we don't want to be needling directly. We can also go peripheral to axial. So we can go gluteus medius, L4 or 5 to S1 to affect the lumbosacral juncture. This is another common one we use all the time, or using all those points in the gastrocnemius and soleus, which are innervated by S1, S2 to affect the sacroiliac joint, which is innervated primarily by S1, S2. So we have a lot of segmental action in acupuncture, stuff we're doing already. So you are going to get a stronger effect to neuromodulate the entire segment if you treat at the spine, so at the axial tissues. There's a stronger effect. It's not to say there's not benefit in the periphery, but needling the spine can make a big difference here. Okay. So there's an effect that I was hinting at, we call spatial summation. So by putting needles in more structures innervated by the same segment, we get a stronger effect to neuromodulate, to bring that segment back into a normal resting state. Okay. So the more structures we needle within a segment, the stronger the dose. That doesn't mean it's better, it's just more. Okay, so sometimes that's helpful for really like stubborn acute problem, or not stubborn acute, a very like strong acute problem. You can needle in this way. It's really effective. So you can have you can do that in the same multiple target layers. So for example, one I like a lot is using the L3-4 dermatome. So just the skin over the medial knee uh, for treating osteoarthritis. Okay, this works really well. And this gets back to something called Hilton's Law. And somehow my Hilton's Law slide didn't make it into this. But Hilton's Law is a this is from the 19th century. It was an anatomist, Hilton, noticed that the joints and the skin over the joints share the same nerve supply. So actually just needling topically excuse me, subcutaneously over the knee can be extremely effective for osteoarthritis pain. This is usually my go-to starting point for that. So I'm using a regional point, but I'm going, okay, I'm going to treat the dermatome first just to see if I can get enough modulation for that patient to have improvement if they're in their knee. You could also add the VMO, that's the vastus medialis obliquus. That's the inner quadricep muscle there. That's also L3-4 dermatome, myotome. So those are all in the same segment on the same side. But we could also do something where, like, for example, we can needle the lateral malleolus, piriformis, uh, sural nerve at bladder 60 or bladder 58, 57, cutaneously to get for the sclerotome, myotome, and dermatome for S1 for sciatica. So that gets you a stronger connection because you're getting all those layers of input. Okay, you can needle contralaterally, as we mentioned before, or we can do axial and peripheral derivatives at the same time. So the PENS, I'm sure many of you have heard of this, that's percutaneous electrical neural stimulation, or Craig PENS, named after Bill Craig, a physician who designed electrical acupuncture protocols that are completely based on segmental innervation. So his goal was to develop initially as kind of a shotgun approach where you would cover if someone has, say, knee pain, you'd cover the sympathetics to the knee. You'd cover to control the blood flow and the stress response and deal with any swelling and so on. And then you do the motor sensory levels, right? Remember, the motor and sensory levels are the same, but the sympathetic innervation for them will be different. Okay. And then intramuscular stimulation, which was developed by Chan Gun, C. Chan Gun. He was a physician from Malaysia who practiced in Canada, Vancouver. And he was a contemporary of Travell and Simons, and he was doing very similar work in some ways to them in terms of needling into trigger points. But what he added and really stressed with the key was to needle the paraspinal tissues. And so that's his big differential pieces. So he would treat the whole spine uh, with needles. Okay. So we have some different strategies. Sorry. Oop, did I stop my thing here?
Yeah,
Sorry.
we just lost your presentation. So
Yeah.
maybe a reshare or
Yeah. I was trying to just see where we are with time for bio breaks and
Oh
stuff. So
yeah, we're at 8:01, so maybe it's a good time sometime soon.
yeah, so what I'll do is I'll finish this slide and then we'll go back to we'll do the bio break. Okay, so let's see where did this go? What just happened here?
Hey, you did have it up and then it just blooped away.
There we
Now
go.
it's coming back up and we're at the beginning.
Yeah, no, I pressed escape and the whole thing got lost there. Sorry, everyone.
Great,
We're coming back. All right, here we are.
great.
Okay, so here are some just representative approaches to segmental acupuncture. Uh, so on the left, top left, there's cutaneous nerve stimulation. This is something I've been really exploring a lot and developing some very reliable techniques actually using this. And that's just subcutaneous needles with or without electrical stimulation. It's not very complex, um, but it can be really handy. Something like some examples that I find really are helpful in the clinic. There's something I teach in my classes about how to needle the skin over the clavicle, and that's remember we is that's the supraclavicular nerves, which are C3 to C4, and you just needle along the skin here and subcutaneously, and you can get really great results to relax levator scapula and the traps and so on, which share the same. They're from the C3 C4 myotome. Um, so a different level, but you're using a dermatome to treat that. So you can often reduce the irritability in those structures a lot. So even if there's a trigger point or some irritability left, you can then, it's much less painful and more comfortable for the patient if you're going to needle that or if you're going to apply some kind of manual therapy. Intramuscular stimulation is a myotome type approach. So that's needling the motor points and trigger points. We actually have Gunn to thank. He's the one who first really thought about needling motor points. Uh, uh, and so you're going to needle them trigger points and motor points and the related sensory motor levels in the spine. So in this case, you're trying to get the multifity primarily. Okay. For the sclerotomal levels, we have periosteal pecking and osteopuncture. Those are the main difference is the use of electrical stimulation. Periosteal pecking is a manual stimulation of the periosteum. Osteopuncture is with high frequency, usually around 200 hertz, 150 hertz uh, high frequency stimulation. This can be really helpful for some stubborn problems. The sclerotome is really strong. You know, treating at the sclerotomal level can be really, really profound for people. And then we have the visceral autonomic modulation or vascular sympathetic modulation. That's from the McMaster folks. And that's just, oops, sorry, that's not supposed to happen. Um, And then this is basically just treating the sympathetic nerve roots related to the nerves related to the problem at hand to improve the circulation. Um, I think Anthony Lombardi calls this perfusion technique, and that's just alluding to the blood supply that you're hopefully affecting. And then there's PENS, which I mentioned, which is a sort of a shotgun technique, which covers all of it. So you're going to cover the sympathetic levels, you're going to cover the sensory motor levels, and you're going to do often peripheral levels relate all within the same segment to affect a pain problem. Okay. So is there any questions before we shoot to nerves? I can take I can take some stuff that's more far out now, but first let's do the germane ones.
Okay, I am seeing a couple questions. So Leon is asking, pecking anywhere on the sclerotome? Question mark.
Yeah, question mark. Okay, yeah, you can peck. You can peck anywhere. So you can peck locally. So for example, like cervical pecking can be really effective for chronic neck pain, lumbar pecking for low back pain, so you can take advantage of that, a very local, strong neuromodulatory effect. But because you can go peripheral to axial, axial to peripheral, you can go any direction with this. You can you know, peck at the head of the humerus, at the two greater tubercle of the humerus. You can peck at the lateral epicondyle. You can peck at the styloid process of the radius or ulna. You can peck at the phalanges. You can peck anywhere, greater trochanter, you name it. So the technique is uh, I've changed how I teach it, but yeah, you can peck anywhere. In the classical man, Felix man, it's using a like a spinal needle, so like a fairly thick, for a hypodermic needle, and pecking the periosteum. That eventually got shifted over into using an acupuncture needle, and then the way I teach it actually is, rather than trying to peck, you sort of gently enter the periosteum and you flick it out, and it makes a clicking sound, but it's when it comes out, not when it hits the periosteum. I find that works better. It's more tolerable, and I find the effects are as good or better. And honestly, the patients don't scream and run away when you do it. But yeah, you can peck anywhere.
Great. A couple more before break. So John Golden's asking, what about using just tens in the cutaneous level?
Yes, that's great. So tens is a segmental technique primarily. So you can do tens on someone's back and affect their knee. Um, you don't tend to get as long lasting effects. There's not the plastic change with tens generally that we see with acupuncture and electroacupuncture. Um, there is something that seems to happen with the needle itself. Um, but yeah, you can use tens as a segmental effect. And coming back to tens, I didn't really talk about electricity, but using electricity within the segment is a stronger dose, right? Because you're making a repeated input, so we either manual stimulation or electrical input increases the message you're giving in the segment. And that's why, we're finding that, like, I'm finding now when I use electricity, I go so much lighter than I used to. I used to be like, okay, you have to like do the gate and you have to overwhelm the whole system and help it, like, but actually they find just the like that continued stimulation of like the nerve pressure nerves or vibratory nerves, uh, that opens the gate. So you don't need to be super strong to make that happen. So that's there's a lot you can do with electricity here. In my practice now, in the past, I was trained. Medical acupuncture was all like everything. You didn't put a needle in if you weren't going to electrocute it, pretty much. But at this point in my career, I don't use it very often. I think I used it. I saw one person today. One person got electricity. Yeah. So.
Great. So, Josh, there's a few more questions in the chat, but I'm going to recommend we take a bio break and maybe you look through the chat and then decide how you'd prefer to address those when everyone gets back.
Sounds great. So we'll see you guys in like 15 or so.
Take
10,
10. Just,
10?
yeah, if that's okay with you. Is that good to go to 8, come back at 8:20? Is that enough? You want 15? Yeah.
No, no, it's just more to, I can talk forever. You guys have to sit and listen. So it's more challenging for
You
us.
know what? There's such good stuff here, and we only have a few hours with you. So how about we do 10, we'll come back at 8:20 and we'll go from there.
Sounds good.
Great. Thank you. See you
Uh-huh.
soon, folks. Yo, 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 we're back. It's 8:20. We don't want to miss a minute of this. I am loving this tonight. Thank you so much. I'm going to turn
Yeah,
it back over to you, Josh.
yeah, thank you. So I just put in the in the chat, I put a link to the slides that you Googled. I didn't see it in the chat, so I want to make sure you guys got that. There's the slides are in there so you can follow along or go back over this. And then there's the cheat sheet that I mentioned, which is a nice 4-page little quick pictures of the dermatomes, sclerotomes, lists of the myotomes, so you can start to understand what you're doing. Other thing is I want to say before we get going on, I am teaching this live in Campbell, California, San Jose area, July 10 to 12, 24 CEUs. A number of you who are here, I know have done that course with me, and I think it's a really great course. Of course, it's mine, so I love it, but I'm also extra critical of it. So I hope to see you there. So you can sign up for that at joshmargolis.net. And actually, next month, our speaker next month, Dan Bensky, I'm also hosting them, Dan and Jay Sandweiss in San Rafael. And that's at Dr. Sandweiss. I can post that one later, but Dan will cover that. There was a couple questions here that I thought were interesting. Caroline, in terms of the interstitium, we don't know enough about the interstitium yet to know how to assess it segmentally. I'm sure there's segmental effects in it, but we don't really understand enough about it yet to be able to track that and have it be useful in the clinic yet. But a really interesting area that many of you probably saw that article in the Times in the last couple days that are really big, interesting thing, which was pretty positive on acupuncture actually, which is good after that dry needling one that came out a few days before, or a week before. Um, Ted asks if we're able to target, differentiate motor sensory and or autonomic somatic nerve roots with acupuncture points or techniques. No. Acupuncture is neuromodulatory. So what you're looking at is when you put a needle in the body's going to do with it what it's going to do with it. Basically, if you make it not painful, and that sharp pain, that's withdrawal or just really strong stimulation, that's going to be a net positive, and you're going to bring things back to normal. So it's not really clear that if we put a needle in, we can, we traditionally talk about tonifying and sedating techniques. It's not really clear if we can push the nervous system in that way. I would be curious. I never learned, setting the mountain on fire and those kinds of things in a way where I could reliably make hot or cold sensation in a patient's body. That does point to some kind of autonomic thing. So I'm not saying it's not possible. I don't know. But we're hoping to just bring the nerves back to a neutral point. So if they're too high, they're firing too much and they're sensitized, we want to reduce that sensitivity and irritability. And if they're under functioning, hypofunctioning, we want to bring it back to a more normal level. Okay. All right. I'm sorry if there's an echo for you. I don't know if you may try wearing headphones. That might help on your end. That's the best I can think of. So anyway, thank you all for being here so far. Were there any other questions before I jump back in? Um, okay. Okay, then we're going to talk a bit about gate control theory and how pain works. I think it's important for us to understand as acupuncturists. That nail we see on the left is a good example of a noxious stimulus. It's much larger diameter and much rougher than our acupuncture needles, which are non-noxious stimuli actually. Sometimes the initial prick, but beyond that, they're detected by the body and as non-noxious. So here's the official definition of pain. So an unpleasant sensory and emotional experience with or resembling that associated with actual or potential tissue damage. So I alluded to this earlier in that there doesn't actually have to be tissue damage to have pain, right? And this is very important, especially in chronic pain. Okay, so nociception is basically a mechanical or thermal event. Oh, we got help from my cat here. This is Chumbo. Um, Mechanical or thermal event or chemical that is causing damage or may cause damage. So like that 125-degree water, or any of you Northern Californians, there's a bunch of us maybe been to Harbin and that 114, 117-degree hot tub, hot pool. It's hot as heck, and you definitely will register pain, but it's not actually going to damage your cells. Okay. So it's to keep you as you approach danger from having an ongoing problem. So, after an acute injury or something, we do have what's called nociceptive pain, which is there to keep you like from walking on your sprained ankle or broken toe. Okay. But pain is a perception that is placed on that neural activity. So you can have pain without nociception, and you can have nociception without pain. Okay. So this is from a great article. There was a 3-part series done by some I think Flemish and Danish researchers, but differentiating the different types of pain. So nociceptive pain is like it's actual or threat of damage. Okay, so someone pushes on you too hard, you may not be damaging the tissue, but it might hurt. Okay, broken bones, burns, chemical burns, all these things go under nociception. Okay. Neuropathic pain is pain from the nervous system. So the nervous tissues themselves are irritated. So you can feel these in all types of places. So that could be like, for example, sciatica, or where you have a radicular compression, some kind of compression, or peripheral nerve compression, or peripheral neuropathy. All of those are neuropathic type pains where it's actually from the nervous system. The pain is generated from the nervous system itself. So for example, in like peripheral neuropathy, the compression might be from like a spinal stenosis, right? A narrowing of the canal in the vertebral canal. But the patient is annoyed by their like burning, itching, tingling feet. Yeah, it's a neuropathic pain. Okay. Nociplastic pain is something we see in the clinic a lot, and this is a very exciting area of research, ongoing research right now, relating to chronic pain. So nociplastic pain is related to sensitization. So that can be some type of central sensitization. So that can be in the brain, and that can be in the spinal cord. And of course, there's always going to be some of both. So a good example of this is like it's looking like trigger points are probably nociplastic pain. That there is a change in the nervous system that the trigger points themselves might be actual perpetuating symptoms caught in the loop related to supersensitivity in the nervous system. I'll come back to that in a little bit. But as you can see with the different types, and you can look at this on your own time, Leon, you're right, this is a really graphic heavy slide, but it's here for your information. You have everything from kind of acute ankle sprain to in nociceptive pain to nociplastic pain, where the whole nervous system has changed. So fibromyalgia, there's nociplastic pain. Rheumatoid arthritis, there is a lot of nociplastic pain. There's supersensitivity. Migraine headaches are nociplastic pain, supersensitivity dysfunction. But other things are related to this. So IBS it follows these same kind of rules on the segmental level. Some types of asthma and so on, as there's a hypersensitivity to both input, and the output is larger than it should be. Okay. There's actual changes in the nervous system itself. So sensory fibers, we have three main types of fibers we're going to talk about in terms of sensation. On the mechanoreceptors, they're A beta fibers. They're very large diameter, they're myelinated, and they have very fast transmission rates. Okay, so this is vibration, light touch, uh, vibration, light touch, stretch, and these kinds of things. Then you have the next one or size down, and we have the A delta fibers. And A delta fibers are also myelinated, but they're of a smaller diameter. They're faster conducting. Myelination is a type of insulation. It allows the signal to jump, which makes for much faster transmission. And this is acute sharp pain, some temperature as well. And A delta fibers, even though they're nociceptors, they are primarily what we're targeting. It seems to be what we're targeting with acupuncture when they seem to be highly mediated by the A delta fibers. A beta fibers are stimulated when we do allowed like electrical stimulation or mechanical stimulation to the needle. So you're getting more input into different parts of the same segment. The C fibers are the small unmyelinated fibers. This last group here, these are slower conducting. This is like dull and irritated pain. A delta fibers are sharp pain. So when you get that needle in, like that quick prick, a lot of that is mediated by A delta and C fibers. But often, if it's just A delta, just kind of primarily A delta, it's just kind of they just go ow, and then it's done. If you really get a C fiber, that's when they get that burning, irritated, like sometimes they'll even get kind of a welt around the needle. So, if you get that kind of sensation, you don't want to do that. You've engaged nociception. So that's why you always want to have the needling. The research really is pointing to really having comfortable needling as much as possible, all the way through the process, as much as possible. So the C fibers and the myelin and the A delta fibers, the nociceptive fibers, have a separate pathway from that of the mechanoreceptors, the A beta fibers. Okay, so here on the left we have this is the dorsal column. It goes up along here. And it goes through the thalamus and then goes to the primary somatosensory cortex. So there's different stopping points, right? So here's a sensory nerve, from a vibration Pacinian corpuscle or something like that, or a gamma motor, a muscle spindle or something like that. And that's coming up here into the dorsal horn or posterior horn. It goes on to the posterior part of the brain stem, then changes position and goes up here, switches sides, goes to the thalamus, and then goes to the somatosensory cortex, the homunculus that we think of. The spinothalamic tract for nociception is a bit different. It goes through and it immediately switches sides, and then it goes up, 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 and it goes to the thalamus. And actually, there are fibers that go to the primary somatosensory cortex, but the newer research is showing a lot of it goes into the insula. And so the insula is a part of the cortex that deals with emotion. And there's some interesting research and conjecture along the lines that, emotions might be a very effective way for us to change behavior. So rather than I'll give you an example. So like heat is picked up by nociceptors, right? So if you get really hot, it's more energy efficient for you to go into the shade, take off a layer of clothing, that kind of thing, than all of the dilation of blood vessels, superficial blood vessels, to changing your heart rate, changing your respiration, making you sweat more. So if you can change your behavior and get out of the hot sun and go in the shade, that's much less work for your organism to stay healthy and in sort of a homeostatic balance point, right? Same thing if you're cold. You shivering is a lot of energy. That's why it makes you warm. So it's really effective way to give you an emotion that says like, oh, I hate being cold. I'm gonna go put a fire on, get a sweat, put a fire on, turn the heat up, get a sweater. It's a lot less energy, more efficient. So we see a lot of emotional aspects to pain and relationships to pain, right? If you stub your toe in the middle of the night, you're not like neutral about it. Some very colorful words might shoot out your mouth and scare your friends, neighbors, partners, whatever, because of that connection to the insula. I just want to remember, when, pain and suffering really do go hand in hand in the brain. So Melzak and Wall, researchers who they ultimately got the Nobel Prize for this, I think. But basically, they found that by stimulating mechanoreceptors, the A beta fibers, that you can shut off neurons. They originally posited that neurons were there, but then they've been since found you can actually close a gate, if you will, to allow that nociceptive information to get to the brain. And so the classic example is, if you in this picture, you smash your hand with a hammer, what's the first thing you usually do? You grab it, right? So now you're adding pressure so that you initiate a nociceptive response by smashing the finger with that with the C fibers, right? And then when you close your hand on it, you go like that. Another one, right? If I bump my elbow in the middle of the night, oh, I rub it, right? So you're stimulating beta fibers. We also do this with heat and cold, TENS units, electrical acupuncture, uh, things like icy hot, like the menthol type things. Those all seem to work in this way. Ultrasound also has some effects along this gate pathway. So, the TENS units sort of trick your body into having, like vibration response. And certainly when you're getting motor contraction, you're getting a lot of input on this gate control area. Okay. So, the question is, the chicken or the egg? Are motor or trigger points actually the cause of pain, or are they the effect of changes in the nervous system? And I think you can say they're kind of a bit of both, but the thing that causes a trigger point to stay in that maintained state of contracture are the changes in plastic changes in the nervous system and sensitization in the nervous system. Okay. I I strong that being said, and I want to say that trigger points are really important to our treatment of pain from terms of Western sort of Western models of acupuncture, but they they while they're in that irritated state, they have a very strong link to the spinal cord, and you have a very good opportunity to modulate the segment from a trigger point. It's a very irritable spot within the segment, so you can have really good effects treating these, which I think we've all seen to some degree or another. Because even if you didn't mean to treat one, we've all needled gallbladder 21, gallbladder 20. Sorry. All right. All right. So there was the integrated hypothesis, and they're just of how chronic pain happens. But basically, what we're moving to this neurogenic hypothesis of how chronic pain works, and that there's changes in the nervous system. So the nervous system gets more sensitized to input, and it changes both how sensitive it is to what's coming in, but also what's going out. And that's part of how we see some of the motor changes, sympathetic changes, for example, in the cutaneous levels, but also the changes in like trigger points and muscle tension. Okay. So that actually it's the sensitization of the central nervous system leads to heightened pain sensitivity. And this happens on a segmental level, but it also happens in the brain. Okay. So, easy way to think of this is we get good at what we practice. This is kind of a hard conversation to have with patients. They tell me, I've had a lot of pain, I can handle it. It's actually you've had a lot of pain. So your system is more sensitive to pain than if you hadn't had a lot of pain. By having a lot of pain over time, um, nervous system actually becomes more sensitive because pain is uh, pain is a sensation overlay to nociception or non-nociception that changes our behavior, right? And so yeah, there's a lot I don't want to get too far off on this. There's just a lot to say there. Anyway, in central sensitization, you have the increased reactivity, which we've talked about in the CNS, the central nervous system, and you're going to see three main characteristics. So you're going to see hyperalgesia, which is the increased sensitivity to painful stimuli. You're going to see allodynia, which is pain from normally non-painful stimuli, and then you're an expansion of the receptive field. So what do these mean? So hyperalgesia means that, like, the Wharton's pinwheel test, the thing that looks like a pizza cutter, or using a paper clip to scratch somebody, something that should be a little painful, the patient might feel quite a bit of pain, even jump, from that stimulation. I use a Tsumoshin, which I didn't bring one. I should have brought one home. I might have one. I'll see if I can run and grab one to show. It's a retractable thing that allows me to put pretty much 200 grams of pressure. It should be a little irritating, but if the patient is sensitized at a segment or on a tissue, they'll jump. This is helpful for writing reports for insurance companies and stuff. You can, like, sensitivity to 200 grams of pressure from a blunt object, that kind of thing. Allodynia is pain from not normally sensitive pain-causing stimuli. So, for example, like the skin roll test, which I'll show you in a little bit. This can get so extreme, like in CRPS, you'll see patients who, like, they can't even have the sheets on their feet. But you'll see a range of this. You'll be like, oh yeah, my feet, not necessarily in CRPS, but you'll see, like, oh yeah, my feet, I can only wear this, like, one pair of shoes, and they're like, I used to love my Hokas, but now they kill my feet, or whatever. So, it's like you'll start to have this shift in sensitivity where pressure of the weight of the person's body should not hurt their feet, right? The under normal circumstances. And then you're going to have expansion of the receptive field. So that means, things that come into body, input that comes into the body can be perceived as pain in the area where that person already is hypersensitized. So, say in a foot thing, someone's foot's hurting, but say they, like, you know, go swimming and they're using their quads more and so on. And they didn't really put too much strain on their feet. They didn't put a lot of flippers on, heavy flippers or whatever. But then maybe their foot could start hurting because, you got L4 on, L5 on the top of the foot. You have some overlap in that. Or the expansion you can even have on the opposite side. People can start to have problems. We'll talk about some more cases about this. So with persistent nociception, nociceptors become sensitized. Nociceptors are those C and A delta fibers that actually changes the dorsal horn neurons and they become uninhibited. And there's inhibitory interneurons. We talked about a little bit in the gate control theory that there are actual neurons that are inhibitory. They release GABA primarily, but they also can be endorphin related. And so these inhibitory interneurons actually will die if there's enough nociceptive input into the segment. And that is a difficult thing to overcome at this point because they don't come back. So you will have, if the person's been in pain for long enough, you'll have a disinhibited segment that will overreact to the information that comes into it. It'll say, wow, that was a big stimulus. And then it'll send out messages to the glands, the muscles, the dermis, everything, uh, in a bigger way than it should. It's going to actually over respond. So you're going to have, as a consequence, you're going to hyperalgesia, that oversensitivity, more sensitivity to painful stimuli, and the allodynia, where that non-painful stimuli will start to feel like pain, right? You ever see, you can see this, like a good example of allodynia, which I didn't mention. It's like, if you stay on trigger points, when someone has a very active trigger point, you can just put a couple grams of pressure and the person's like, whoa, stop, yeah, wait, stop pressing on me so hard. Okay. So this concept of sensitization can spread contralaterally to segments above and below the original segmental level of input. So that's the expansion of the receptive field. So there's been some interesting, Siegfried Mensa has done a lot of research on this, where they found like injecting cytokines into an um, irritating I think the hamstring muscles of a rat, and then they found that the tibialis anterior of a rat, and then they found that the like TFL and the hamstrings became like super sensitized in a pretty quick time, and there's variance in those segmental innervations. Okay, just remember that the nociception here, aka piston Honda, will cause an increase of sensitivity. And that increase of sensitivity, that spinal sensitization, is a two-way street. It's both sensory and motor. So it takes less to irritate the segment and make the nerve fire. It has a bigger response, it has a prolonged response, and then the motor output will be changed as well. Okay, so with central sensitization, and I'm sorry if I keep using these terms sort of interchangeably. It's basically spinal sensitization. Spinal segmental sensitization is a subset of central sensitization, which means that the central nervous system has become sensitized, which is differentiated from some of the peripheral sensitization, which is like right when you just burn yourself or cut yourself and so on. Okay. But we're going to see this. We're probably going to have seen this kind of dumpster fire of effects in our patient population. So we have things like increased fear and anxiety. So the limbic system's affected. We have poor concentration, again, like hypothalamus, limbic system here. We have sleep disturbance. We have sick role behavior. So people like, I'm always sick, I can't do that, or, avoidance and so on. You have pain catastrophizing. I see this a lot in patients, and you're like, you treat them a few times, they're getting better. You're like, how are you? Like, it's the same. I can't do anything about it. So, it's like, I never, and you're like, well, what happened? Well, it hurt for like an hour yesterday. And like, but to them, it's huge, and I'm not making fun of them. It's like, this is how our nervous system has evolved to keep us safe. And then an interesting one is you'll see sensitivity to sensory input. So the limbic system is very connected to the sense of smell. So a lot of people um, very sensitive to smell, chemicals, other kind of input that shouldn't normally have a huge response, right, in the nervous system, right? You smell a dryer sheet. Is that stuff toxic? Yes. Should it give you a headache for 3 weeks? No. Should it make you sick, throw up, etc.? No. So, you have this overreaction, oversensitivity in the nervous system to input, right? But you see, if we look at sensitivity, sensory input, sleep disturbance, increased fear and anxiety, pain catastrophizing. This is most of our patients with fibromyalgia, chronic fatigue syndrome, now like all the Lyme syndrome stuff. These all have a huge central sensitization component to them. And I think this is really important for us to recognize in the treatment of these populations. If you don't address the central sensitization, really get people sleeping better, doing different kinds of desensitization programs. Like there's a whole bunch of them. Curable, uh, the Gupta method, uh, uh, dynamic neural rehabilitation system, primal trust. Those are four that I can think of off the top of my head. Are programs that play a role in dealing with all this central sensitization, especially from the brain level and the top-down control. So I'm not saying you can control everything from the segmental piece and just really paying attention to your patients and helping them with this, telling them they're not crazy, that they feel insane pain, and whatnot. It really, really helps. It's normal. This is how our nervous system keeps us safe. Okay. So this is just coming back to this. This is just very important. So I kept this slide in here a second time. So here's a slide that I made to kind of show the two-way action here. This is in your handout. Okay, so you got it. But it's going to show how this goes to both ways. So here we're in orient. This is the posterior part of the spinal cord. This is the anterior. Okay, so it's that posterior horn. This is that lateral horn and the anterior horn. So we can have, if you follow the color code here, we can have contralateral switching over. We can have, we're having pain in the quadriceps, but then we're also sending along here, we're having the dorsal root reflex, the red, which is now irritating the quadriceps and sending chemicals that are irritating, which can promote the formation of trigger points, for example. We can have osteoarthritis. Osteoarthritis is actually, some of the research right now is pointing to it as being maybe a consequence of segmental sensitization, that the some of the irritation is very similar path to formation of trigger points. Kind of interesting. You can have the same thing happening in the back. You can have it move up and down segments. You can have the in the skin, you can have like pain in the skin here, there's sensation here, dorsal reflex. So you're gonna have subcutaneous edema here, so painful skin rolling, difficulty in the skin roll. You're gonna have sweating. That's meant to be it's a pointer plus, showing that there'll be pointer plus. A lot of our point finders, the way they work is really magical, not magical. It's just that over that cutaneous area that's irritated, there's going to be more sweat a lot of the time. So that's lower electrical resistance. So beep, it makes a noise, right? If it's calibrated right. So we can use point finders sometimes to find this. We're going to have this is the pilomotor response here, the erector pili, the hairs stand up. We're going to have the sweat, skin rolling, that's all from the lateral horn. We're going to have a change in the muscle tone here, a change in the muscle tone in the quad. So all of this is happening kind of all at the same time. And we have autonomics and these kinds of things going back and forth. So this is a lot going on in this slide. I get it, but the key takeaway is that you can have sensory input altered. You can have the dorsal root reflex, which is what sends like irritating chemicals, pain-causing chemicals, nociceptive sensitizing chemicals down into the target tissues that are innervated by that sensory nerve. You're going to have the altered motor output and tone. You're going to have altered autonomics, and you're going to have the potential for spreading outside of that segment up or down the chain or to the other side. Okay. All right. So we're coming to the end of the slides here, that what I need to talk to you about tonight or want to talk to you about. So like, what do we do, right? So this is according to Fisher, is a physiatrist who was doing interesting work on trigger points. But basically, you just need to identify the pain. You need to assess for the spinal sensitization. And so you're going to apply whatever treatment that you're going to do. and then you need to remove the etiologic factors, right? So I had a patient, older guy with low back pain, was one of his things. And, you know, I spent some time teaching him how to get up out of bed, get into bed, and get up and down from a chair. That took care of probably of his more about his back pain than what I did with it in terms of treatment, other like direct treatment. So you got to deal with the etiologic factors as well. Okay. But this is an ongoing circle. You know, really need to have a clear assessment of what you think. If spinal sensitization is part of the thing, you need to be treating that as part of it. Okay. So we're going to see some of the clinical. This is all from Chan Gun's website. He's since passed, but these are still available. So he uses something called the matchstick sign. So when you take like the back of a tube, you can use that to press the skin. If it leaves a mark, then you know there's edema there. That's on the left. Then this is orange peel skin, or peau d'orange, which is French for orange peel, but you can see that it looks kind of like an orange. When you depress the skin, you'll see that. Sometimes when the irritation is enough, you can see it without even touching the patient. And then we have here, this is thickened skin folds, and you can really see the peau d'orange. They're squeezing the orange peel skin. They're squeezing that. So facilitation, facilitation is the osteopathic word for spinal segmental sensitization. It's the same thing. So this, you can see an altered red response, and I'm going to show you a video in a moment. And then you'll see changes in skin drag, which is related to the sweating. So you'll feel like little places where your skin it'll stop. And we're at 8:57. Is it okay if we go to like 9:05 or something like that? You guys will be okay with that?
That's definitely going to work.
Okay. If you need to bug out, feel free. All this stuff will be recorded, and there's also you have access to the slides and such. Okay, so here's a video from a class I taught in New York a couple years ago, just for this section. You come close. See, there's some peau d'orange. Even without touching them, there's peau d'orange. There's some swelling under the skin, those little raised areas. Got someone here. Got one here. So you just already with observation, we can see quite a bit. Oh, you got a little breeze came through. You see more goosebumps came up, right? All mostly in those areas that I just described. You know, if we were mean, we could do that. But you can see it. Yeah. All right. So what we're going to do first is the skin drag test. So this takes a little practice. You want to try to get your fingers kind of even. So you have to stand at a little bit of an angle. Otherwise, it torques your wrist. So you want to be really relaxed. And so that you have to be a little off behind their spine. And what we're going to do is we're just going to slide until I feel a difference and a change. So right there, right there, right there, 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 there. So what I'm doing is gently rubbing my fingers over the skin there, and you'll literally feel the skin will start to drag, and you can't slide as easily. This takes a little practice in the clinic because it's easy to press too hard, and then you're always dragging, or you're going too light, and then you're slipping on it and you just slide over it. But with practice, this becomes very, very reliable, and this is a really good sign. This is checking for hypersympathetic activity at that segment. So there's going to be a change in the sweat. There. See how that lines up with the things? I pointed this out to you. If I do it closed, with my closed eyes, you'll see it'll stop in pretty much the same spots.
What are you feeling that's different?
Look. Skin.
Yeah.
It's tacking. Yeah, nothing. I'm not even feeling it. It's just with my light pressure, I stop moving. Yeah. So I land on those same spots. So we have now two confirmations. We have a visual confirmation, some peau d'orange, without even having tested him, and skin drag. Now we're going to do is the red response test. And we could take that all the way, but you know, it gets harder when people are hairier. So the skin drag's harder when people have hair because you just slide on the hair. It's not impossible, but it's just
modify your test for your audience, right? So this is, I'm going to use the same position. So I'm going to bring my fingers kind of vigorously down your back here a few times, okay? So you're going to might feel a light, warm sensation. And we're going to watch. Okay, here comes the red.
So this is the red response test, which I mentioned earlier, which is testing the vasomotor response. And so you'll see with things that are more in the acute, subacute phase, they'll be long-standing red areas in it, and you can even see sometimes it'll just kind of bloom. We've all seen this when you needle, like in the bladder meridian or the Huato Jiaji. Sometimes you'll see these big spots. And that's not for like people who have dermatographia. Some people this test doesn't work because, you know, you could like say like Josh was here at 4:30 doing acupuncture and they'll be there the next day, right? You know, just with your finger. So so it's not for every patient, but this is a useful test. Especially I like to do it in my first you know few visits to determine and verify.
So everybody should turn red, but look at that. That's more red right there. That's one of our zones. All in this zone where we had and along here, that red is staying longer. This side it didn't stay long. Red is long. Okay, we still are red in some of these areas. Okay, that's red response. So that lets you know that those segments are irritated. Okay, these regions, oh, that's different. You see the quality of the difference? So there's a pot orange popping up right there, especially right there.
So I'm just looking, bringing my hands together here. I'm not skin rolling yet, but just getting a sense of like, what is the skin tissue like? Is it cooler? Like because of the vasoconstriction, you will feel the skin in an irritated segment is cooler. You can feel just with like gliding the skin lightly with practice, you can feel like, oh, this area moves really freely in the skin and this one feels sticky. And you're just rolling the dermis basically over the muscle layers.
You look for like crepey skin too, like that.
Yeah, you can, but you see how there's this kind of pattern right here where it's really, it doesn't take a lot of force. You can see that it's handy to generate.
There you go. You can see some of that pot orange right there in these
there.
in the area between when I push my hands together.
You see that on him, you can already see that in the skin. Much thinner. So the left was much thicker.
So the pinch and roll test is checking for allodynia. So normally just rolling the skin on the back should not be painful in a normal segment, in normally innervated segment, happy segment. But in unhappy segments, this can be quite painful and it can be almost impossible to even lift the skin off the muscle layer.
Beginning, now it's starting to tighten up, but not as much as on the left side. How you doing, Taryn?
I'm doing okay. I mean, it's tight, but not.
Yeah.
There, it's kind of uncomfortable.
So it's the same kind of level.
Actually, that's quite uncomfortable.
Yeah. And that starts thickening. Can you guys see how here I'm here before he says uncomfortable?
See how thin that is?
How thin. And then as I come here, thicker, and now it's hard for me to grasp. You see how that happens? And he starts saying uncomfortable. And then that starts to ease a little bit. And then that's starting to thicken a little. And then we start, it's not as thick as on the right, on the left, but it's still thicker. So that's the test. In real time, that doesn't take as long as it did for me. I would just go like, tell me when this starts to hurt. And then if there's any areas that particularly hurt, let me know. And then you're going to either mark it with a marker or something like that. I have washed.
Okay. So that's a handy video that you can look at. We can look at to see those tests in real life. So that's really quick. In the clinic, the skin drag test, this is like doing the entire spine. Okay, I've just done an entire spine. Zing, zing, zing. 30 seconds and then 20 seconds, and then you just roll the skin. So that whole thing takes about a minute and a half to do. So getting into sort of the nuts and bolts of treatment, I alluded to some ideas and some clinical things, but here's the basic, upping your game with your Huato Jiaji. So you're just going to needle right next to the spinous process. So where like Phil Shih and Shaw, some of the physiatrists who are doing this work and research, they're really trying to get the medial branch of the posterior primary ramus of the spine. So that's basically, I got this spine here. So, that's an area where when the spinal nerve comes off, there it splits into the ventral ramus, which will go to the front part of the body and the limbs, and you have the dorsal ramus, which will go or anterior and posterior. It's interchangeable, but basically there's two branches, and one goes right along here and into the interspinous ligaments and so on. So the due meridian, governing vessel, and then the Huato Jiaji, we were probably taught in school just like a half inch out. I'm talking like right as close as you can get to the bone. You're not trying to hit the bone, but with practice, you'll find there's a little sweet spot where you can kind of slip between the muscles, and it's not very painful. It's easy to get in there. So needling like that, using primarily rotation, you can leave the needle there, and then you can go back and test. Those tests I showed you in the video. I only showed the spine, but you can do skin roll on all the meridian. I mean, all the dermatomes. You can check it did after you needle. Did the trigger point change palpation? Is there a change in their range of motion? All those kinds of things. But we should see a change in most of the tissues throughout the whole segment if you're super accurate. So sometimes here I do use a point locator, or I use the Tsumoshin device. I can try to get a picture of that and see if I can really find the spot that's super sensitized on the spine. But yeah, you can treat with acupuncture, you can treat with manual therapy, whatnot. Here's a picture kind of showing that. Here's some, periosteal or sclerotomal type needling right here on the left. We're needling, into the due meridian, so into the interspinous ligament, the supraspinous ligament. You can also just tap the periosteum on the spinous processes. And here's kind of showing how you're trying to do your Huato Jiaji needling. So we're sort of in between Huato Jiaji and the due meridian here. And I'm not doing this, I'm just rotation. Sometimes, and I show this in the class, I do like an osteopathic myofascial unwinding on the needles, which is really, I find works really well. Okay. Just want to wrap up with another one of my favorite quotations from the founder of osteopathy, which is, "To find health should be the object of the doctor. Anyone can find disease." So this is what we're trying to uncover, is find that health. Like osteopathy, acupuncture modifies how the system is working and helps it work more efficiently and effectively. And I think these modalities or approaches have a lot to teach each other, which is why I'm bringing Dan Bensky and Jay Sandweiss out in October. And this is why I'm teaching you some things that, these tests and things that I showed you, those are straight out of beginning osteopathic school. Some information here about the upcoming class. I did this with AI. That's why this person has 22 lumbar vertebra, which is great. And their dermatomes don't match. But anyway, it was quick and easy for that. So I'm open to question and answering. I appreciate you all coming tonight and taking time out of all of your busy schedules and your lives to spend some time with me. I hope to see some of you in person in July. I think there's a lot to be learned here from this approach, and it's not this is not for me to try to like convince you that this way is better or whatnot. It's a lens. So if you do distal acupuncture, you can do distal acupuncture and maybe you can understand what areas might be more effective for you. And when you can check at the spine, or maybe you even just think of adding like the bladder meridian or the Huato Jiaji points in. So, you know, I want to just thank you all for coming and spending a couple hours with me tonight. So.
Oh my goodness. Thank you so much, Josh. That I'm gonna take your class, so I'm really excited for that. I don't know why if my video's coming up or not. Uh, all right, either way. Yeah, I know there's a few more questions in here. I see we've gone a long way. What I'm wondering is maybe we'll gather up those questions from the chat and maybe I don't know if
Actually, I was wondering if can people email you directly, Josh? I think that would be easiest.
Yeah, if you have additional questions, you can email me or call me at the office, or you can text my office. So on the first slide is my contact information. And down here, this is just my booking website. So that just goes to Jane and you can book for a class. But if you have specific questions, I'm happy to chat with you about this work. I think it's added a lot to my like reliability and complex and understand like feeling like I'm like, okay, like as much as we can understand, which is only a small, it's an iceberg, right? We only get the little tip that we get to understand. But it's like, okay, at least I feel like I'm a master of my 2 inches of iceberg. And maybe if I can get to 3 inches next year or in the next decade, I'll be happy. But it's like, okay, start to understand what's happening in patients and how like what goes wrong or how they were mistreated, like why did this person go to the chiropractor and it was so irritating? They're like, well, they do this really heavy stuff. And if they're sensitized, they're doing like ART, for example. And I don't mean to be knocking on chiropractors and physical therapists, massage therapists, acupuncturists, ourselves. I mean, this is just like, why did that irritate this patient so much? Why do they have pain after the thing I always do that fixes people's tight quadriceps, or whatever, and it's so irritating it can be so irritating to their system if they don't have the elasticity or resiliency in the system, because acupuncture itself is a stress you're applying to the system and saying, here, system, I'm going to stress you in a very particular way and see if you can respond by normalizing yourself, right? When you needle someone, there's a spike in sympathetic activity initially, but then it tends to drop down lower. And that's when your patients, passed out and they're like, I fell asleep. I didn't even know you were gone for 20 minutes. And then it should hopefully come back to a more normal resting spot. And then as you repeat that, you go through that process. So the spike gets less, the drop gets less, and then the normalization becomes more stable, right? And that's what we're really trying to do here. Um, no matter what style, this is not meant to be dogmatic. I'm not saying this is better or worse, anything. It's just a lens that I found really helpful to understand what I'm doing and where, especially in my practice, is like mostly chronic pain, where I can interface safely, effectively, and reliably, and get results. Because then you're like, oh, who's this person? If I'm seeing these signs of sleep disturbance, sensitivity to sound, like the patient who comes in is like, oh my God, my neighbor was like talking to their friend until like 11 o'clock and I couldn't sleep. And then and then they were smoking outside of my house and I couldn't stand it. And I couldn't, and then like ruins or catastrophizing and all these things come together. You're like, that is not a patient I'm gonna like needle a trigger point on, probably. Not
Yeah.
for a while. You know what I mean? It's not, we may get there, but it's like I'm gonna come in with the gentlest thing, maybe an ear needle, maybe just talking, like, and just looking at that spectrum of sensitization. And then you get like, super healthy athletes and you can like get your tent post needles and a hammer and they're like, ah, thank you. And they resolve and they feel amazing. So looking in that perspective and seeing where people land. So enough of my my babbling. So
Well, I see a lot of chronic pain. Of course, I do pediatrics only as my specialty, but chronic pain is one of my specialties. So I'm going to take this class with you July 10 through 12 in Campbell, which is the San Jose area, right? Am I correct about that? Yep. And then next, so Josh, thank you so much. There's so many questions here. We're going to have to bring you back either for a live program or another one of these because I think folks haven't had enough of you, but it's been a late night. I started 7 a.m. So we're going to be wrapping this up now, folks. And what you've got to do is come back the second Tuesday of next month because we have Dan Bensky joining us, and that's just going to continue this discussion, but in a unique way. But again, like looking at palpation, touch, and I'm sure a really great dive because Dan's an osteopath also, right, Josh? So yeah, so come join us next month. We're so excited to keep learning together and just appreciating the depth and breadth of this incredible medicine we get to practice. Thank you for joining the CSOMA community. Thank you for forwarding your continued questions to Josh. We will bring you back somehow and stay tuned for updates, legislative updates that are happening in California and how to support those and advocate for our medicine and our patients. And we'll see you the second Tuesday of next month.